Hi there. Thanks for joining us today for Clearing the Air, Understanding Allergy and Asthma from a Physician's Perspective. We are so happy that each of you could join us for what we are sure is going to be an informative session. I'm Jennifer Noonan. I'm the Senior Director of Clinical Programs and Compliance here at Accessia Health, and I'll be your moderator today. Before we get started, I'd like to cover just a few housekeeping items. First, all lines will be muted throughout the duration of the webinar. However, we welcome you to submit any questions throughout the event through the Q&A section on your screen. We will have time at the end of the presentation to answer any questions. For the convenience of some viewers and those who are hearing impaired, closed captioning has been turned on. This webinar is being recorded and will be available at accessiahealth.org. We will also have polls throughout this session, and we hope that each of you will participate as they pop up on your screen. Now for a small disclaimer, Accessia Health webinars, events, and conferences are intended to provide information to the public. The views and opinions that are expressed by any speakers or other third parties are not necessarily those of Accessia Health. And so without further ado, I'm excited now to introduce our speaker for today. We have with us Dr. Naveen Sikka. He has been practicing in the field of allergy and immunology since 2008. After completing his internal medicine and allergy immunology training at the prestigious Henry Ford Hospital in Detroit, he has worked in the field of allergy, asthma, and immunology for 14 years. Dr. Sikka's expertise covers all areas of allergies and immunology, but he specializes in nasal and eye allergies, asthma, sinusitis, hives, angioedema, chronic coughing, eczema, primary immune deficiency, and allergies to foods and medications. In his daily practice, Dr. Sikka is dedicated to teaching patients about their allergies so that they're better prepared to stay healthy. He incorporates evidence-based medicine to provide the latest up-to-date techniques, such as allergy immunotherapy, biologic therapies, and oral immunotherapy. Dr. Sikka has treated thousands of patients and is committed to providing the best personalized allergy care to the community.
Thank you, Jen, for having me.
Yeah, so glad to have you. All right, so we're gonna have, I thought we were gonna have a poll. I'm so sorry, 1 second. All right, so let's get started by asking just a few basic questions. First and foremost, can you tell us what the role of an allergist is?
Absolutely, happy to do so. So welcome, everybody. I'm excited to tell you about my field of allergy, asthma, and immunology, because a lot of times it's unknown exactly what an allergist can help with as far as medical conditions. So we are specialists in, of course, allergy medicine. And what we do is provide services to patients that are suffering from a variety of allergic disorders that can include seasonal allergies, pet dander allergies, food allergies, and medication allergies. And then, of course, all the variations that those diseases can create that can affect the body.
So did you say head dander?
I meant, if I said hand, I meant pet dander is what I meant.
Well, you might have said pet dander,
yeah.
but I might not have heard it correctly.
Yes.
So I wanted to ask for clarification.
Yes. No, primarily we all love our house pets. So cats and dogs are a huge trigger for allergic disorders. And one of the things that I help assist with is allowing patients to hopefully stay healthy with their pets still in their homes, because a lot of times they're a huge trigger for severe allergic disorders.
Yeah, I think that's a great question. I'm glad that you addressed that. So you're saying that with proper treatment, there are lots of options for being able to keep your pet and stay healthy as well?
We try our best. So that, of course, if you want to follow the absolute scientific guidelines, the hard and uncomfortable rule is that the pet has to be removed from the home if you are truly allergic. That is easier said than done. Most patients will say, I will never remove the pet from the home, and I'm a pet owner myself, so I can understand that sentiment. So instead of being, such an aggressive approach of removing the pet from the home, which is a difficult scenario to achieve, I work with patients to try to see if we can find a solution to desensitize them against their allergen. And then with that potential therapy, they can hopefully retain the pet in their home with less disease burden.
Great. Thanks for answering that.
Pleasure.
So can you tell us real quick, what is every allergist and immunologist? I've heard the phrase utilized in the past, and I'm wondering if they're the same or if they're different.
They are the same. So it's a unique subspecialization that occurs after a physician finishes primary medical training. So there are two avenues of primary medical training that leads up to becoming an allergist. So you can either go through medical school and then finally go to internal medicine, which is a training program that treats people in adult medical disorders. Or you could also finish medical school and then go to pediatric medicine and then become specialized in pediatric medical care. From there, if you want to become a specialist in the allergy field, you have to do an allergy and immunology fellowship or subspecialization. And that is an extra level of training after the primary medical training has been completed. So it is a subspecialty that requires further education from the primary medical training.
Okay, that makes sense. Thank you so much. And now we'll go to a poll. So if everyone could try to participate on their screen and select an answer, we'll see what everyone thinks, and then we'll ask Dr. Sikka if those are true or not.
Hey, we did good. We did good.
Okay.
So yeah. So, of course, we always miss school for being ill in some form or another, whether it's a cold or a flu illness, or in other cases, allergies. What we're trying to get at here, what we're trying to hint with this poll is that actually the majority of the people that miss school or work, 70 to 80% of the time, the underlying reason to miss school or work is actually an allergic disorder. And what's interesting to mention is that allergic disorders are the underlying trigger for people to become more ill or have a potential to become ill with colds and other viral infections and asthma as well. So it's always the allergy first and then the cold or the flu or the asthma that sometimes comes on board afterwards. That's not the case for everybody, but like I said, for about 80% of the cases, allergies can be associated as an underlying trigger. And if you control the allergies, then the risk of getting sick from colds and flus goes down.
That makes sense. So prevention does go a long way in this case.
It does. It does.
Okay.
It's just the inflammation that the allergic disease creates in the respiratory cavity, whether it's the nose or the lungs, is a perfect hotspot or kind of a nidus or a hotbed for bugs to set up shop and create an infection.
Okay. All right. Let's see here. Move on. Is there another poll question? I think that. So help us just understand the basics of what exactly is asthma.
Sure. So in the basic definition, it is a chronic inflammation of the bronchial airway. If we can review the anatomy of the lungs, as people remember, we have the windpipe, and then that divides into the right and left sides. And those windpipes further tree branch into these smaller tubes called bronchioles. And at the end of the bronchioles, we have the alveoli, air sacs, which is where oxygen exchange occurs, where we get oxygen in our bodies, and then the carbon dioxide or the CO2 comes out. So we want that airflow from the mouth of the nose to go into our lungs and into those air sacs as easily and as fluidly as possible. And I apologize, my light just went out. There we go. And by having a nice open airway, we can get nice air movement in and out of our lungs. What asthma unfortunately does is it creates those bronchial tubes to constrict and narrow, and then that leads to difficulty with symptoms of breathing trouble, such as shortness of breath, Some people may wheeze, some people may have a cough, and others will have chest tightness. Some will have all of them. And so we want to make sure that we address that issue, because obviously breathing is one of our most vital functions, and we have to make sure that we oxygenate our bodies correctly. And so we have to use, of course, medication therapies to help resolve that inflammation.
Great. So are there different severity levels? Can it range
Yes,
from person to person?
absolutely. Absolutely. There are typically what we classify as 4 different levels of asthma severity. We have the lowest or the least aggressive, which is the intermittent asthmatics. These patients usually have flare-ups, once or twice a week. Some of them may have it as an exercise-induced component, while others will just have it from some type of allergic trigger. 60% of asthmatics do have an allergic trigger for their asthma. So we want to make sure that we address the allergies as an underlying culprit. There's another percentage of patients that will have exercise-induced asthma. And I want to clarify here that they're not the same. Some asthmatics will kind of mention to me, hey, I don't have trouble when I'm exercising. I only have trouble when I'm around my animals or when I'm outside in the park. And we want to differentiate that there is a difference between allergically triggered asthma as well as exercise-induced asthma, and they have their own different triggers. So not everybody has the same triggers for their condition. So the mildest case, like I just mentioned, is the intermittent asthmatics. And then if patients start to have more frequent symptoms, then we consider them persistent asthmatics. And then there's a level of severity based on their measured lung capacity, which we measure via a device that we call a spirometer in the medical office. And we use the spirometer to see what level of airway flow obstruction or constriction there is in the bronchial tubes. And they're broken up into 3 different parts: mild, moderate, or severe persistent asthmatics.
So does it seem to have a different range as far as age goes, or do we see differences in onset? Help us understand.
So most asthmatics will have an early onset of age, usually in early childhood, between the ages of as early as 6 months of age, all the way up to the age of 5 in the pediatric population. But there is no hard and fast rule that asthma cannot develop later in life. I have seen some onset of asthmatics or asthma disorders in teenage years. And then even in late adulthood, some asthmatics will start to develop symptoms after the age of 40 or later. So there is no age specific, time to become asthmatic. We used to believe it was only a childhood illness, but that has changed over time now to show that there's a wide range of new asthmatics that can have the disease suddenly.
Okay. All right. Well, it's time for our next poll question. It won't let me answer this, but
Yeah, me either.
be curious to see
We're-
how it lands, because I'm not sure I would have answered right or wrong. We'll see. Okay.
Oh, good. Everybody got it right. So, yeah, sometimes I get these consultations and I'll hear this a statement mentioned that, hey, I don't wheeze, doc, so I don't have asthma. I go, and so then I'll say, well, what are your symptoms? Well, I'm coughing all the time, or I feel short of breath when I'm exerting myself, but I never wheeze. So it's not, I was told it's not asthma if I don't wheeze. And that's a bit of a misunderstanding of the science there. Wheezing is a symptom of asthma, but typically wheezing is a symptom when the asthma is milder. If I can equate our bronchial tubes to a musical like instrument, like a flute or a windpipe type of instrument, where if you narrow the tube, then it, like a straw, for example, you can buzz it and make some sound. I know this is kind of hard to visualize, but you have to have certain amount of air flowing through the tube to make that wheezing or musical sound. If the tube is constricted further, then it's harder to move air in and out of that tube. So then wheezing is usually, that musical sound is not heard. But because there's still ongoing constriction, there are still symptoms, other symptoms such as coughing and wheezing. I'm sorry, my apologies, coughing and shortness of breath. And so I always want to make sure that the patient that mentioned that to me, that I don't wheeze, so I must not have asthma, but I cough all the time, or I'm short of breath all the time, that we address that this still could be asthma, and we don't want to miss the diagnosis just because there's no wheezing.
Yeah, that's great. It's a perfect segue into the next little section of questions, because I think for me, I have also heard that a lot in my past history. Patients who assume that because they don't wheeze, they must not have asthma, and so you dispelled one of the bigger myths, I think.
That's a big one. And coughing, like by coughing alone, sometimes is a big one. That's a hard one to sometimes tease out, because coughing alone is sometimes blamed as a non-asthmatic illness. And that's not always the case. There are some patients that have what's known as cough variant asthma, where the only symptom is a cough. They have zero shortness of breath, they have zero wheezing, and they have zero chest tightness, but they cough chronically. And they get an anti-asthma therapy, and all of a sudden they start to be healthier.
Yes, that's great. So another myth that I would like to ask about is, I have heard before that sometimes people can say be stung by a certain number of bees over a period of time, and that will produce in effect, a barrier to being allergic, if you will.
Right.
Can you help us understand that?
Yeah, so what we're talking about is like auto desensitization, I think is probably the best way to describe that. And it's unfortunately not perfectly accurate that it can help protect you from a bee sting allergy if you suffer from that condition, because you don't know what dose you're getting with all of those injection stings. When we do desensitization in the medical clinic or the allergy clinic, we have a standardized dosing protocol that we must follow, that has been vetted by science and research to show that this is the dose that's going to truly desensitize you from the allergen, whether it's the bee venom or an environmental allergen. And by just self-treating with stinging aggressively or being outdoors more, unfortunately doesn't work, because the exact volume of what you're receiving is unknown. And because there's a haphazard exposure rate, as well as no consistency with the exposure, because one of the other things that's important with allergy desensitization is a consistent frequency of injections every week or every month, depending on your situation. That is missed with that's a missed opportunity when you try to do it yourself, or assume that multiple stings will protect you. And so, no, unfortunately, that doesn't work to help you get better.
It also seems a little bit dangerous. And
of course, and that's, I didn't even mention that, because
painful.
If you truly have if you have a bee venom allergy or any kind of venomous insect stinging allergy, it can be a life-threatening reactivity. And we don't want to have somebody in a situation where they are in an unsupervised setting and getting exposed to those allergens. Yeah,
for sure. So can you think of any other myths that you are accustomed to hearing in your practice that you might want to make sure that the folks watching are able to get squared away today?
Yeah, it's I think it's one of the poll questions. I don't want to interrupt that poll question. There is one that kind of highlights when is the right time to see an allergist. I'll let that question come up here in a minute. The other thing is that there is, when can we test patients? What's the right age to test somebody for allergies? And a lot of times I've heard these unfortunate myths that there is no available testing on the patient until the patient's 5 or older. And that is a big myth. There's no such limit that's imposed in the science. We can test as early as infancy if we need to.
Okay.
And here's the question here that of, what's the age to see an allergist? So let's see what I think I probably already hinted at the answer here, but we can see what the audience believes or knows.
Yeah, I assumed there was probably some sort of age limit on it, but
Yeah.
it's very interesting to know. Let's see.
Yeah, and that's perfectly great. So there is no age limit, and that's exactly right. That the age limit was really I don't exactly know how it was created as a phenomenon, but no, we as allergists, most allergy immunology doctors, even though we have, and I should back up here and talk about, remind people that we have either internal medicine trained allergists or pediatric trained allergists. But once you go into the allergy and immunology field, you are certified to see all ages. So
Mhm.
even though you were adult medicine trained and then went into the allergy field, or you were pediatric trained and went into the allergy field, once you go into the allergy field, you are allowed and flexible to see all ages. And so we know that food allergy disorders and respiratory allergy disorders can occur as early as 3 to 6 months of age. So we see a lot of babies that will have trouble with feeding, failure to thrive, which is inability to grow correctly because they're not digesting food correctly due to digestive issues with the food that they're consuming. Some babies will also develop eczema at that early age, and that could be a food-induced allergy trigger for that eczema. And then, of course, a lot of respiratory illnesses can lead to wheezing and asthmatic-like symptoms due to RSV or other viral infections, where an allergist may need to be involved in helping them manage that disorder. And so, yes, we see all ages. And as far as allergy testing, like I mentioned earlier, there is no limit. If we need to test somebody at the age of 3 months, that is totally fine and safe to do. There is no harm to the child to do that testing. And there is no imposed limit. I think it was just something that was a perceived risk because it's potentially quote unquote dangerous. And I want to dispel that it's a very safe procedure. And knowing the answer to their allergies is going to be way more helpful in managing that patient correctly.
Yeah, that's a great point. And actually leads to a question I think that may not come up as frequently as many of the others that we see. But when you talk about a small child, an infant that might have the development of eczema or, other types of symptoms that you might think would be related to food or environmental allergies, it would also be important to look at the foods being consumed by a mother if it was a child that was
Yep.
nursing at the time, because they
Yep.
are passing those nutrients through. Is that correct?
Absolutely. If there's a breastfed child that is developing eczema disorders or digestive disorders, then we need to look at the mother's diet as well, because the child may be at that moment sensitive to that particular food, and that's what's leading to their medical condition. There's a phenomenon of what's known as the atopic march. Atopy or atopic conditions is the medical term for allergic conditions.
Mhm.
And it's just another way to say allergies. And unfortunately, we do see that early onset allergy inflammation in the child can then lead to further allergic disorders as they get older. So we want to make sure that, yes, we address their dietary triggers if they have such triggers, and then also make sure that we monitor these babies as they get older so that we can make sure we address any other allergy disease developments. Because once the eczema maybe gets better with the treatment, unfortunately, it leads to other development of asthma disorders or seasonal allergy disorders after they get older, past the age of 5 and onwards.
Okay. So this next little portion, we were going to talk about access to care, but let's first talk about what it is that we need to access. What is your typical treatment for allergies first?
Yeah. So if we're talking about seasonal allergies, if we're talking about nasal congestion, runny nose, sneezing, or watery eyes, with the nasal condition that's called allergic rhinitis. Rhino means nose in Latin, and itis means inflammation. So allergic rhinitis is just allergic inflammation of the nasal cavity. So if people have a stuffy nose constantly, or a runny nose constantly, or sneezing all the time, that's something that can be quite a nuisance and can affect their quality of life. It's like they have a constant cold, but they're sick for weeks or months on end rather than just a couple of weeks, like a typical illness. Then they're definitely seasonally allergic. And the best way to initially start getting better is to start taking an over-the-counter antihistamine. There are many now available over the counter, such as Zyrtec or Claritin or Allegra, if I can mention some brand name products that are easily accessible and are age appropriate based on the instructions on the box. And then also helpful, which is now over the counter, are nasal sprays, specifically nasal corticosteroids. Very safe and effective medications for people who have chronic nasal congestion or runny nose symptoms. Those are usually the first lines of defense for nasal allergy symptom patients. And if that fails, then typically we then say, okay, time to go see the allergist to see what else is going on here. You know, is the medicine the right dosage? Are you taking the medication correctly? Because that's always an important thing to review. And then if you are, maybe we need to upgrade you to something stronger because the over-the-counter remedy was not successful. The other issue, which just kind of goes hand in hand with seasonal allergies, is ocular allergies or eye allergies. So watery and itchy eyes can also be part of that process of allergy exposure that leads to inflammation of the nose and the eyes. And it's that bombardment of the tissues of the eye or the tissues of the nose that we can't see. These are microscopic organisms or particles that are in the air that once we inhale or expose our nasal tissues or eye tissues to, that leads to inflammation and then the subsequent symptoms of irritation.
Is there a treatment for that?
For the eyes, yes. There are also antihistamine eye drops now that are also over the counter that can be helpful for certain patients if it works. Sometimes, unfortunately, there is a threshold of what will work for certain people. Usually, when it's a milder allergy patient, the over-the-counter remedies may be sufficient, like a Zyrtec a day or a Claritin a day may do the job. Some people might need an eye drop once in a while, but typically, if you're taking those medications and following the directions on the bottle and you're still symptomatic, that's the time to consider seeing an allergist, because at that point, the over-the-counter plan has failed. And then moving on to respiratory symptoms, if you start to have coughing, wheezing, shortness of breath, then the concern could be, are you developing asthma or do you have asthma? And in that situation, that's something that is a bit more of a concern because obviously it's affecting your breathing now, and that's something that we don't take lightly. And then in that situation, we need you to have somebody take a look at your lung capacity, listen to your lungs, see how you're developing these symptoms, and then of course address them so that you get the proper treatment.
So can you tell us how you find out what kinds of things are being done in order to derive at the answer of what someone's allergic to?
Sure.
I imagine that's probably changed a little bit over the years. And
actually, the process is very similar. People might be familiar with allergy testing, and the gold standard or the testing that most allergists will offer in their office is what's known as a skin prick test. Previously known as the scratch test, which is now changed to more of a prick. So before they would take a small amount of a purified extract of a certain allergen, say it's dog dander or ragweed pollen, and then we'd place it on the back, and then we would scratch the skin with a sharp device to introduce that allergen into the top layer of the skin. And then 15 minutes later or so, we would see a local reaction occur on the site of the exposure, which would then be interpreted as a positive response. Now, instead of actually scratching the skin, we just do an up and down poke with a similar device. It's less irritating to the skin, so it's not as traumatic, and again, very safe for all ages. And that gives us the same results in about 15 minutes to see which environmental triggers the patient may be suffering from. And the triggers vary region to region, so it depends on what part of the country you reside in, but there are various different pollens that can be unique to your environment. So it's ideal to get the testing done in your local environment to make sure that you're getting the proper testing for your condition. If for some reason a skin prick test cannot be performed due to some kind of medical condition, or sometimes patients just don't want to go that route, we can then offer a blood test instead, which is just a single poke in the arm to draw some blood, and then we can check similar allergy responses in the bloodstream. We usually do that as a secondary option because it's not as clinically accurate as the skin prick test. So if we're trying to get the best answers for our patients, the skin prick test is the preferred modality.
And when you were talking earlier about bee stings and how really that's not a very accurate delivery method for, that's kind of how you all figure out what the patient has reactions to, and then the dosing is just very standard
Right.
based on the scientific data, so that what's being given is custom.
So correct. This is where the personalized service comes in, because we use the testing as a guide to personalize your the serum. The allergy serum that we use to treat the inflammation is personalized to that patient. So we use whatever was reactive on that skin allergy test as the formula to create the serum for allergy desensitization. So talking about how to manage patients that fail medication therapy. So we kind of hinted at this earlier, that if you don't respond to the Zyrtec or the Claritin or the Flonase, which are the over-the-counter remedies, and we are trying to now control your allergies better, the allergy desensitization, which is known formally as allergy immunotherapy, the reason it's called that is it's an immune modification therapy. And this is where the immunology portion of an allergist training comes in. Allergy disorders is an immunologic disorder. Your body is overreacting to the environment and then causing the symptoms that are causing the disease. So there's a lot of times a phenomenon of, oh, I think I'm weaker in my immune system, which is why I'm getting sick all the time. And I have to reverse that or flip that. In the allergy world, the opposite is true. You're actually overreacting to the environment, which is why when you inhale these particles, instead of taking them in quietly and processing it and not causing nasal inflammation or eye inflammation or asthma, your body is attacking it and then causing the inflammation to cause the symptoms. And so that's where the disease comes in. So when we try to use medications, we're trying to suppress that inflammation. And then when we're trying to desensitize, and this is the immunotherapy or the allergy shot therapy that we offer our patients, that's what we're trying to retrain the immune system to say, okay, we know you're reacting to this stuff, but we need you to not do that anymore because you're causing inflammation and causing discomfort to the patient. We want to stop that process. And that's where the desensitization comes in. And again, we can do it for environmental allergies, pet dander, pollen, certain mold spores, dust mites. These are the big triggers environmentally that we worry about. And then we also do have it for specific venomous insects. I'll highlight those as well, because this is important to mention that people can be allergic to bee stings, honeybees specifically, yellow jackets, hornets, wasps, and fire ants. So those are the big ones that we worry about as far as stinging insects that can be desensitized if patients have what's known as an anaphylactic or severe allergic reaction to the venomous stings.
And is this also how you would treat food allergies? And maybe you said that at the beginning. And
no, so the foods is a bit different. So great question.
We
can do skin prick testing. So say certain patients that have say anaphylaxis to foods, if they eat a certain food, such as a peanut or a seafood item, and they get hives or lip or tongue swelling or breathing difficulties within a few short minutes of consumption, that is a sinister reaction or a severe reaction to a food. And that's a dangerous condition that can threaten the person's life. In those situations, up until a few years ago, all we could do is tell patients to avoid that particular food because there was no standardized way to control that inflammation or prevent that disease from reacting when the patient was exposed. There's current research going on, and it's being offered in what we classify as an off-label or not FDA approved therapy, but because it's such an important therapy and a game changer, it's being offered more and more now in the community. There is a phenomenon of what's known as oral immunotherapy, which is different than the allergy and immunotherapy for allergy, environmental allergies, because oral obviously is under the tongue rather than injections in the arm. Injections in the arm are FDA approved for environmental allergies and bee venom allergies, but they are not safe for people who have food allergies. There have been studies to show that it can lead to more severe anaphylactic reactions, and that can be very, very dangerous. So at first we were between a rock and a hard place saying, okay, how do we help these patients? And then there are some senior allergists that have worked very diligently to try to find a solution here for these patients that had these severe food allergies and have been on this path of discovery and now offering treatments that can help patients do a oral desensitization to their specific food allergen. And by doing so, they can do one of two things. They can achieve a higher threshold so that if there's an accidental exposure to a certain food, it won't trigger anaphylaxis in those patients. And then in certain cases, we can achieve full desensitization where the patient can eat that food again in their diet without any reactivity. And that's a really impressive feat that has been recently been able to be achieved. So very promising. It's still considered off-label, so I do want to highlight that again, that this is currently not a, except for one, I should clarify that there's a peanut protocol that is FDA approved. But the other foods are not currently approved. Hopefully they will be approved shortly, but a lot of us as allergists are still worried about our patients and we want to help them as best as we can. And we, in certain clinics, will offer that desensitization as long as the risks are well explained to the patient and their parents. Usually we can proceed safely.
That's pretty exciting to be.
It's very exciting. It's one of the biggest kind of modern kind of changes that have occurred in the past few years. That's really been a game changer for a lot of these children and certain adults too that have lived with their food allergies for many, many years.
Mm-hmm. That food allergies are very difficult, and I always feel terrible for folks who have to limit what they can eat.
Yeah, it's and I'll kind of add one more thing to it, which is kind of the opposite side of the coin, where we also don't want to just, if you don't have that history of anaphylaxis, food testing should not be used as a screening tool. A lot of people offer that as a service, and I want to dispel or discourage that approach because not everybody's food allergic. It's not as prevalent as it's made out to be. Only 2 to 8% of the population has a true food allergy. But it's kind of a buzzword nowadays to say, oh, I think I'm, allergic to a certain food, or I'm sensitive to a certain food. I must be allergic to something because I don't feel well. And so we want to make sure that we tease out the right population of patients and not and get the right testing for those patients that truly need it, and not use it for people that do not have those conditions.
Oh, that's good to know. Can you tell us about biologics? What are biologics?
Yeah. So another advancement in our field in the past few years has been the development of what's known as biologic agents. Biologics, in a kind of a simple definition, is an antibody that is developed in the lab that has a specific function to block or modify an antibody's function or response in the body, in the human body. So if we have an inflammatory antibody that's causing disease, we'll take asthma as an example because that's what I treat. And so we know that in certain asthmatics, there are a couple of antibodies that cause allergic inflammation in the lungs. And that's what drives the inflammation that causes the disorder. And so we can give a biologic agent which blocks that antibody, and then hence the patient improves because now that antibody is not attacking the lungs and causing disease. And it's been a game changer for our field because there are some more severe cases of disease where we would try our best efforts to control their patient's symptoms and nothing would work. And so we had no other option, unfortunately, except to use a lot of steroids or prednisone, which is not a good long-term solution because there's a lot of harm involved with those treatments. And so biologics has been a revolutionary advancement in our field of allergy care because now we can use these antibody blockers to improve the person's health without steroids, and their quality of life and their disease burden goes down significantly.
How are those administered?
Most of them are injection based. There are some exceptions to that where there's some pill options, but because the biologic molecule is quite a large molecule, it has to be usually injected into the arm or into the belly to get it properly delivered so that it can perform its function. So in the majority of cases, greater than 90% of them are injection-based therapies.
And are these treatments FDA approved and indicated?
They are. These are FDA approved, and they all have their own unique indications. And they all are have certain criteria that you have to meet based on clinical criteria as well as insurance criteria. Once you meet that criteria, then yes, it is something that will be very, very beneficial to those patients.
That's great. Do they receive these medications in the office setting, or do they take them at home, or is there a combination?
There's a combination. So it depends on the situation. There are certain drugs that are FDA approved for home use.
Okay.
Most of the time, though, in-office administration is the norm. It is just a safety risk. Sometimes the drugs require some monitoring post-injection. That's important to do in the clinical setting so that we can make sure that the drug was received correctly and there were no adverse events or reactions from the medication. And then the other thing that also I just like to mention is a lot of times it's just a comfort to know that the patient is under the care of a clinical setting that can address any concerns that may arise when they're getting their injections. And then the clinical team can also evaluate them if there's anything new that develops as far as their disease state. So it is recommended that most of these injections are done in the office.
That makes sense. They'd have support around.
Yep.
So if someone is, we kind of talked about myths earlier, and there's been a couple of questions that have come up. I thought I would address one that came to mind also is about honey. So, we've heard that raw honey in small quantities or large, who knows if it's going to be good for your blood sugar, right? But that honey from a local source can be helpful for your immunity. What can you say about that?
So unfortunately, that's a big myth, unfortunately, to be honest with you. It's something that has not been proven to be clinically accurate. Honey does collect a lot of pollen, and the bees that pollinate those pollens are collecting pollen from various plants to create the honey. The unfortunate thing is the plants that the bees pollinate or carry pollen, the pollen that they carry, are not allergy inducing pollen. So it is something that does not have the right pollen formula, so to speak, that will help desensitize patients. The other thing that gets mentioned is, well, obviously the pollen circulates through the air. Every pollen is an airborne allergen that's microscopic. We can't see it. And so maybe the honey will pick it up in your local vicinity, and then by consuming it, you'll get these, again, that same phenomenon of kind of the same analogy of being stung multiple times. You'll get exposed, and then that'll help desensitize you. The problem with that is that you don't know what the formula is in that particular bottle of honey. It's not a standardized dose, so you won't know what concentration is being consumed. It may have nothing at all, or it may have way too much. And I've seen reactions, unfortunately, where people have consumed local honey and have had either large mouth sores, lip or tongue swelling, or even full-blown anaphylaxis because they consumed the local honey and then had developed a reaction that put their life at risk because they took such a high quantity of that particular allergy-containing honey. So it's a risk that I would not recommend patients follow.
Wow. Yeah, thanks for answering that. I had no idea. I have a question just that kind of came to mind for me, because we do have some interest in population of patients that have primary immunodeficiencies. And I know that it's something that takes a really long time sometimes to get diagnosed. Do you see that your practice and setting area is a good place for people to start if they're seeing chronic illness in a smaller
Yeah,
child?
absolutely. So, usually if the good thing is in most academic centers or in most metropolitan areas, infants are screened for a lot of the immune deficiency disorders as part of their screening evaluation when they're born, because we want to catch these illnesses, especially when there are immunologic disorders that are genetically noted at the time of birth, because they can be a life-threatening condition if it's not picked up early enough in the first couple of months of life. And so definitely, getting that screening done for those babies is an important part of an evaluation as part of being born. If patients develop immune issues later in life, and this is the disease that most allergy immunology specialists will treat, there's a condition known as common variable immune deficiency. This is a later onset disorder that can occur in teenage or young adult ages, where the body doesn't produce enough antibodies to fight infections. And the common infections that we see in this condition is chronic sinus infections or chronic respiratory infections such as bronchitis and pneumonia. And so if you have a history of chronic recurrent sinus infections or chronic recurrent bronchial infections, one of the things that I will screen for, and most allergists will do the same thing, is to look for that primary immune deficiency. And the word primary means that it's something that your body did on its own to create this disorder, and that's what led to the immune deficiency syndrome. They're very rare. That's the good news I can pass on, that I don't catch a lot of these cases. I would say about once or twice a year I'll see somebody who has this disorder. But yes, an allergy/immunology specialist should know how to work up those conditions. So if there's a history there of these recurrent sinus or pulmonary infections, definitely seek out an immunologist that can help assess that issue.
Okay, great. A couple more questions on here, and then we can open it up to see who else has questions. Let's go ahead and do this last poll question really quick. So it says, how long before you see a physician? How long should you let symptoms persist before seeing a physician for allergy-related issues? Let's see what everyone says. I wish I had a drum roll sound.
And
Play it before we see
or some kind of Jeopardy background music.
That's even better, yes.
All right, so like kind of a smattering of answers. I mean, there really is no right answer here. It's really kind of based on level of inflammation and severity of inflammation. Obviously, I would love to see anybody who has an allergic disorder, because if you come to me, I'll give you my best effort, to get you under control. And we are, of course, the trained specialists for this area. But a primary care doctor can definitely help, as well. And I don't want to disparage my primary care colleagues or even ENT colleagues. They are definitely well versed in handling a lot of these conditions as well. So sometimes it's not easy to get into an allergist right away. So your primary care doctor can definitely help in getting some initial care going. Typically, what I would suggest, though, that if symptoms persist despite trying over-the-counter remedies or even prescription remedies from your primary care colleagues or primary care doctors, then we should address the possibility that you may need desensitization or immunotherapy, because that is something that will be a more formal and game-changing therapy for our patients. So typically what I say is, if you're suffering year in and year out, every spring, every fall, or even year round, and you've tried the over-the-counter, nasal sprays, antihistamines, you've even required a couple rounds of antibiotics a year or a couple rounds of even steroids a year to control your disease, and you're still okay, but you're still feeling, blah or not fully normal, that may be an indication to come to an allergist so we can address those concerns and get you on a better program, because there is no reason to suffer. That's one of the biggest things I'll mention here, is that you don't need to suffer. This idea that I got to live with my allergies because this is just who I am I want to stop that way of thinking, because that is not correct. Desensitization is a game changer for a lot of patients. And I've highlighted the immunotherapy as an injection therapy. And then we talked about oral desensitization for foods. There is also an oral desensitization for environmental allergies. So a lot of patients that don't like the idea of shots for their environmental allergy control can qualify for drops under the tongue as well. So there are all the alternatives to the environmental desensitization that can also be still providing that game-changing level of improvement. And what I mean by game-changing is a very important kind of percentage that I like to mention, because it's usually a shocking number when I say it. Most patients, when they get on medication therapy, such as a nasal spray or an antihistamine, may get 50% improvement of their symptoms, maybe a little bit more, maybe a little bit less, but that's the best that we can usually achieve if they're using that medication correctly and on a regular basis. With allergy desensitization to the environmental program, we can usually achieve a minimum improvement of 80% reduction of symptoms,
80?
if not 80%, exactly.
Wow.
And usually it's higher. Usually it's even higher than that. And that's why it's such a game changer for a lot of patients. And it's underutilized because there's just either the unknown phenomenon that this therapy exists. So I'm happy to be part of this webinar today, because I want that word to get out that there is a reason why allergy specialists exist out there in the community. But again, it's that level of control that is a game changer. And on almost any given day, I'll hear a patient tell me, I wish I'd started this sooner, doc. I wish I knew about this sooner, because I feel so great now that I'm on this therapy.
That's fantastic. So impactful.
Yeah. It is one of the few things. I mean, it's a great specialty. I mean, if I can just, tell my own personal experiences here, this is something that I have seen such a wonderful change. Something I can, like you said, impact positive change in our patients. That's exactly what we do here in the allergy world.
That's great. This next screen just shows some of our various programs that we have currently, and the highlighted ones are ones that we feel all definitely fall into the realm of allergy and immunology. There's a few more on here that I thought might fit in there, but we don't really need to focus on that, other than to say there's a lot of different symptoms and disease processes that very well could have some preventative measures if people are seeking out treatment from your specialty. I do have a few questions that have popped up. I want to make sure we get to those. And then, of course, if anyone else has anything now, please feel free to drop it in the QA. So what if I went to my doctor and they gave me a prescription for Singulair, but I already buy Zyrtec over the counter? Does it matter?
It is, yes. It's a different medication altogether. So great question. Singulair is what's known as a leukotriene blocker. Leukotrienes are one of the compounds of allergy inflammation in the body. What leukotrienes do is create congestion in the nose and constriction in the chest. So it's FDA approved to treat both nasal allergies or rhinitis or asthma. And actually initially it was approved for asthma first, and then got the nasal allergy indication later on. But it is a different medication than an antihistamine. Antihistamines, as they suggest, block histamines. Histamine is another compound that causes a lot of allergic inflammation. That actually is considered the principal compound in allergy disorders. And histamines can cause sneezing, itching, redness of the skin, or itching of the skin. And so slightly different symptom triggers that occur with histamine compounds compared to the leukotriene compounds. So in a lot of cases, when you are prescribed the Singulair product, also known as montelukast generically, their equivalent, then we're doing that as an additional therapy in addition to the antihistamine to try to help control the various symptoms that the person may have.
Okay. There's one more question right now in the Q&A, and it says, when do you feel that a food allergy is severe enough for testing or just avoiding a food?
So, it's a great question. Testing is always used as a guide. And I always want to highlight that when we do testing, we're using it to confirm a suspicion of a specific disease, whether it's food testing or a blood test for some other disorder. We as a clinician should get the proper history from the patient first to say, okay, tell me your symptoms. What happens when you consume this food? Are you getting the classic features of a food allergy reaction? And this is important to highlight that there are specific food allergy reactivity symptoms that are unique to the food allergy test. And then there are other symptoms that can occur that are not exactly food allergic reactions, but they're more digestive or intolerant reactions. The unfortunate thing with a lot of those symptoms is that there is no magic test for those particular foods. There are some exceptions. For example, there's one for celiac disease, which is the gluten intolerance. There is also a lactose intolerance test that is available for people who have a milk digestive issue. But beyond those two, the rest of the testing that's offered in the allergy world is specific to anaphylactic type reactions, such as peanut-induced reactions or nut-induced reactions or seafood reactions. So again, the testing is based on the history. So if you're not sure what type of testing is required, or even if you have a true food allergy reaction, or what is the reaction that's occurring, it's best to see an allergist to discover and discuss the various nuances of that particular history, and then we can guide you better on which test is necessary, if it's even necessary at all. What I tend to find a lot of times is people want to get the testing first because it's offered as a yes or no answer. And unfortunately, it's not that simple of an answer. It does require a proper history to discover exactly what is the symptoms that are occurring before we can make the proper diagnosis. And then we're using the testing to just confirm our suspicions or deny our suspicions of that particular disorder, and not using it as a end all. Oh, yep, you're allergic, or no, you're not, because there are many cases where it's either false positive or even in some cases false negative. And then we have, to discuss what that means and how to properly manage those patients further. Sorry for that long-winded answer, but it goes into this. This is where it's more complex, and unfortunately, I see a lot of times there are some tests that are being offered out there in the public, and sometimes direct-to-consumer marketing is working really well to offer these tests that unfortunately are not being properly educated as to the risks involved with that test and the results, what the results mean for those tests. So always seek the opinion of an allergist if you can, because they will give you the best advice regarding if the test is appropriate and if it's necessary.
Great. We have about 2 minutes left. There's a question about eczema and just wants to know if it's always related to allergies.
So for many years, we used to believe it was, and the term was even labeled atopic dermatitis. Atopic, again, as if you recall, means allergic dermatitis. And we used to believe that there was some type of either food or environmental trigger. Now we found that that's not the case, that the actual inflammation that's going on in the skin is allergically inflamed skin. We see a lot of histamine in there. We see some other allergy compounds in the skin. But we've learned now that the actual trigger is more of a genetic mutation in the skin barrier. So the skin is not properly sealing in the cell walls, so moisture comes out, and then that is what leads to the inflammation. So again, there's some patients that do have a food trigger, but usually that's limited to the pediatric population. Once the eczema develops in more later stages in life or persists beyond the age of 5, then typically it's not a trigger by an environmental or a food allergy. It is just the genetic mutation of cell wall dysfunction. And so at that point, we just have to treat the disease more symptomatically. And the good news is those patients can not worry about their diet or their triggers because there will be no other benefit to doing so.
That's great. This was such a fast flying hour. I learned so much
fast.
today. I wanted to thank you so much for coming and talking with us today.
My pleasure.
For those of you that are on the call, we thank you very much for joining us today for this information session. We do encourage you to complete the brief survey that you will receive after the webinar. It helps us ensure that we continue to provide helpful information and content. And if you're not already doing so, please follow us on social media at Accessia Health to learn about our other presentations and upcoming webinar series. Thanks so much for everyone's time today, and I hope you have a great day.
Thanks, everyone.